that we have the drug that we are using for any purpose, okay, it's going to produce the beneficial effect for which we are taking drug, but this drug is also responsible to damage the human structure as well, so it may cause side effects, adverse effects, or toxicity. So in case of antibiotic use, what do you mean by selective toxicity? It inhibits growth of bacteria without damage to host. And definitely the host is human beings, in which we are using uh, antibiotics against the infection. So selective toxicity means selectively inhibit growth of bacteria. And there are different mechanisms that we will see in the subsequent slide. So how we can inhibit the growth of bacteria or multiplication of bacteria by inhibiting its protein synthesis, by inhibiting formation of nucleic acid synthesis, by inhibiting its cell wall structure, right? So selective toxicity means antibiotic specifically inhibit different structure of bacteria, not the different structure of human cells, right? So that is why selective toxicity means inhibit growth of bacteria without damage to host. And why it does occur? Due to differences between bacterial and human cells at four major sites. Number one, cell wall. Number two, cell membrane, ribosomes, nucleic acids. So these are the different sites where antibiotic produces its activity. And on the basis of these sites, we can also classify antibiotics into different groups. That means one of the group that is responsible to inhibit growth or kill bacteria when it's going to act on cell wall, and there is another group that act on cell membrane, and there is another group that inhibit the synthesis of protein by acting on ribosomes and nucleic acids. Correct. Characteristics of antibacterial agents: spectrum of activity. This is important. Spectrum of activity means how this antibiotic is effective against different group of microorganisms. As you know, there are different group of microorganisms. Like, even if we just talk about the bacterial infection, this infection could be due to gram positive, gram negative, aerobes, anaerobes. So these are the different groups. Spectrum of activity means if antibiotic is effective against only a small group or specific group of microorganism, that would be labeled as the narrow spectrum. But if any antibiotic that covers more than one group, right? So it could be labeled as the broad spectrum antibiotic. And why it is important to know? Why it is important to know? And what is the importance of broad spectrum uh, activity of any antibiotic? In emergency situation, if a patient come to the emergency department having severe infection, so the antibiotic that we are going to select should have broad spectrum activity. Why? Because one important point I want to share with you, that ideally it is recommended before starting any antibiotic. This is important point, so you must focus on this point. Before starting any antibiotic, it is mandatory to send the uh, blood for the culture and sensitivity test, right? So why we send this patient blood for culture and sensitivity? To check whether this uh, the, whenever if you have a chance to see the blood culture report, in which you will find that in the report there are specific antibiotic, and they mention in front of each antibiotic whether organism, the susceptible organism, the causing organism is showing the resistance against that antibiotic or showing the sensitivity. Resistant means this antibiotic would be ineffective if we use against that organism, because with the help of blood culture and sensitivity in short term we use blood CS. Okay, we are going to perform this patient blood CS. Blood CS stands for blood culture and sensitivity. With the help of culture we identify the organism, and with the help of sensitivity we find out, okay, against this organism what are the antibiotics showing the sensitivity or showing the activity. So whenever if you have a chance to see the blood culture report of any patient, and you will see that there is a list of specific antibiotic, and against that antibiotic either they have mentioned R or S. If R is mentioned, that means this antibiotic showing the resistance. So that means we are not going to use this antibiotic in this patient. If antibiotic showing S, that shows sensitivity. That means this antibiotic can be administered in that patient, right? So, okay, so what we were talking about, if a patient come to the emergency department, right, with severe infection, okay, we will send the blood for blood culture and sensitivity. But in that situation, in that emergency situation, uh, because this emergency situation due to severe infection, we cannot wait for the result of that blood CS report, right? So in that situation we'll have to start the antibiotic. So which antibiotic we'll have to select, because at that time we don't know which group is responsible for this infection. So definitely in that situation we'll have to select antibiotic that can cover different group of microorganism, right? So that would be labeled as broad spectrum, and this treatment or this therapy is labeled as the empirical therapy, right? So what is empirical therapy? When we don't know the organism and we are going to start the antibiotic, broad spectrum antibiotic that can cover different group of microorganism, right? That therapy would be labeled as empirical therapy, right? Okay, after getting the result, so what we are going to check, we are going to check that the antibiotic that we have started, if that antibiotic is showing the sensitivity according to that report, patient report, so we will continue that antibiotic. But the antibiotic that we have started and showing the resistance according to the patient blood CS report, so we are going to change that antibiotic and we will start the antibiotic according to the blood CS report. Okay, so this is the detailed discussion of this practical point that we are doing on daily basis in our wards or in our emergency department, right? So this broad spectrum already we have discussed, active against both gram positive and gram negative bacteria. Examples are tetracycline group, quinolone group. Narrow spectrum, active against one or very few types of bacteria like vancomycin. This is one of the example of antibiotic for staphylococci and enterococci organism. Now the characteristics of antibacterial agent. Again, this is one of the most important terminologies. One of the term that we use bactericidal, and another term that we use bacteriostatic. So there are antibiotics that has the ability or capability to kill the bacteria, right? So that would be labeled as bactericidal. And bactericidal antibiotic, if we compare with bacteriostatic antibiotic, bactericidal antibiotic supposed to be the most powerful antibiotic, right? And these are useful in life-threatening infections because in severe infection or life-threatening infection, that means the viral burden, the load of that organism is so extensive, right? So extensive, so we can get the quick result if we are going to decrease that burden by quickly removing that organism from the body by killing them, right? And also useful in patient with low WBC count. That means definitely if a patient having low WBC count, that means having low immunity, right? So in that situation, we'll have to use the powerful antibiotic. So we are going to use bactericidal antibiotic. This is important point. Bacteriostatic, the antibiotics that inhibit the growth, multiplication of the organism, but do not kill bacteria, right? So one important point, when the everyone everyone having microorganism in their bodies, but not everyone is going to develop infection. You know why? Because our natural immunity or innate immunity is going to stop or kill the low number of microorganism if our immunity is intact and working well, right? So there is no extensive multiplication because when signs and symptoms develop, when specific number of microorganism is going to develop in the body. Suppose there is a threshold value, for example, if the number of organism increases more than 10,000, right? This is one of the example, for example, right? Then it will show the sign and symptoms related to infection. But if it is like 5,000, 6,000, so there is no development of sign and symptoms. Clear? So that is why one of the important practical points, a patient having infection, right? So there is an antibiotic which is suggested for that patient, and after two, 1 or 2 or 3 dose, the fever is subsided, which is important indicator of infection, right? But in some patient, right, this fever is not subsided up to 2 or 3 days. Why does this happen? Because of microorganism burden, right? Suppose the one of the example in which the fever is subsided after 1 day, that means that patient having less burden. Suppose it crosses 10,000, and when we start the antibiotic the burden is 20,000, right? So this burden is decreases, and when it reaches less than 10,000, the fever is subsided, but microorganism is still there. So that is why we focus or we convince our patient, you must take this antibiotic for at least 5 days or 7 days according to its viral burden that we observe as a clinician, right? This patient having severe infection, mild infection, moderate infection, right? So this is one of the reason, because some of the patient, when the fever is subsided, you have recommended that you must take this antibiotic for at least 5 days, but when fever is subsided, now patient thinks, okay, there is unnecessary to take, why should I take this antibiotic for further 2 days or 3 days? Suppose he or she has taken antibiotic for 3 days and there is no fever during this period. So now they start thinking, okay, I think my infection is subsided and that is unnecessary to take further 2 days dose of that antibiotic. No, because this fever is subsided because we have decreased the burden, but organism are still there. If we stop therapy, now that organism has the opportunity to multiply again, and when again it will crosses the threshold value, again signs and symptoms infection will occur. So when there is complete removal of microorganism from the body, so there is decreased chances of recurrence of that infection, you know. So this is the explanation of the duration of antibiotic. Like in some patient 5 days, in some patient 7 days course, in some patient 10 days course, in some patient 14 days course, right? So this is all about the duration, right? So we were talking about the bacteriostatic that inhibit but do not kill bacteria. Bacteria may grow again when drug is withdrawn. This point already we have explained. Host defenses are needed to kill bacteria, right? So the remaining antibiotic that is bacteriostatic inhibit the further multiplication of bacteria, inhibit the overburden of microorganism, right? So the remaining bacteria that must be killed with the help of that defense mechanism of that patient. So that is why in immunocompromised patient, like in the bactericidal antibiotic, we have seen why it is so useful in the patient having low WBC. That means they have immunocompromised patient. So immunocompromised patient host defense cannot kill the bacteria. So in that situation, we cannot use bacteriostatic drug because bacteriostatic drug requires the host defense mechanism as well, because it will inhibit the further multiplication of microorganism. But the microorganism which are already existing, how they are going to destroy, right? So in that situation, that is why we commonly use bactericidal drug, right? So in large doses may become bactericidal. This is very interesting point. Normally antibiotic if it's bacteriostatic, but if we have no alternative, suppose bactericidal antibiotic may be harmful if we use in that patient due to renal failure, due to other comorbidities, and suppose we have only choice to give the antibiotic and that antibiotics belong to bacteriostatic group. So how we can overcome this problem? If we increase the dose, that uh, antibiotic become bactericidal, from bacteriostatic to bactericidal. Now this is very important slide. Already we have discussed there are different sites where antibiotic produces its activity, right? So in the previous slide we discussed that there is a site that is called cell wall, cell membrane. When we enter inside the cell, there is another site that is ribosome, responsible for protein synthesis. Then the nucleus, at the nucleus level, there is a group that act on and the nucleus level and inhibit the synthesis of DNA and RNA by inhibiting nucleic acid synthesis, right? So this you must know the different group of antibiotic on the basis of their site of action, where they are acting in the bacteria. So number one, there are different group of antibiotics available that inhibit the cell wall synthesis. You know, cell wall. Why cell wall having importance in the structure? Because it is responsible to maintain the cellular structure of that bacteria. If we are going to inhibit the this cellular structure, this cell wall, now cell become fragile and it can be ruptured easily. So when the cell is going to rupture, that means we are going to destroy or kill that bacteria. So the group of antibiotic that inhibit the cell wall synthesis, basically are bactericidal drugs, right? So major examples, we have penicillins, we have cephalosporins, vancomycin, bacitracin. So these are the key examples of antibiotics that inhibit cell wall synthesis. There is second structure, the cell membrane. And again, one important point, right? Said antifungal drugs. This is one of the group against fungal infection, and most of the drugs which are included in this group, they are going to act on cell membrane, right? So injury to plasma membrane, polymyxin B, nystatin, amphotericin B, or azole group, right? So this is the second side, and the third side is the inhibition of protein synthesis. So there is a broad group of antibiotics, right, in which we have different subgroups, and the main group is the protein synthesis inhibitors. And in this major group, we have uh, different subgroups of antibiotics that is going to produce its activity by inhibiting protein synthesis, right? There is a long list in which we have a subgroup is a group is aminoglycoside, right? Macrolides, right? Tetracycline, streptogramins, macrocyclic structure, right? So these are the different subgroups under the heading of protein synthesis inhibitors, right? So this is a few examples: erythromycin, tetramycin, tetracycline, but there's a long list of drugs which are included in this group. Inhibition of enzymatic activity, right? So one of the activity for the multiplication which is required is the formation of folic acid, and folic acid is required for the synthesis of purine and pyrimidine, which are the essential building blocks for the synthesis of DNA and RNA. And you know, DNA and RNA is required for the multiplication of microorganism. So if we inhibit the enzyme which is responsible for the synthesis of folic acid, we are going to inhibit the building blocks for DNA and RNA, that is purine and pyrimidine. So this is how we can inhibit the multiplication of that organism, in which we have the different sulfonamide group like sulfamethoxazole, trimethoprim, pyrimidine. So these are the few examples. The another group is the inhibition of nucleic acid synthesis, directly nucleic acid synthesis. So when there is no formation of nucleic acid synthesis, so it would be difficult so for the synthesis of DNA and RNA. Uncertain side of action, we have different groups in which we are not sure about its mechanism of action, but these drugs are very important drugs that we are using clinically, and which one of the common example, that is the metronidazole, and INH, that is isoniazid. Isoniazid is used in the treatment of tuberculosis, and metronidazole, the very famous market name, that is Flagyl, that we use commonly. Group of antimicrobial agents, and already we have discussed according to mechanism of action, there is a group of antibiotics that inhibit the cell wall synthesis. There is another group that inhibit the cell membrane function, basically antifungal drugs that follow this mechanism of action, inhibiting or altering the structure of cell membrane. Inhibitors of protein synthesis, inhibitors of enzymatic activity, inhibitors of nucleic acid synthesis. There are two important terms that we can use. Number one is the MEC, that is the minimal inhibitory concentration. The minimum concentration which is required to start its antimicrobial activity by inhibiting the growth and multiplication of that organism. And MBC, minimal bactericidal concentration, the minimal concentration which is required to start the killing of microorganism, right? Killing of microorganism. So that is called the minimal bactericidal concentration. What does it mean? How we are going to explain this? Because if we suppose sometimes when we start the therapy, patient is not responding, normally it should respond, right? Suppose we have selected very accurate antibiotic, right, and there is no mistake in the selection of antibiotic, but in spite of that, that antibiotic is not showing the response or showing the response but slowly. One of the mechanism could be from the physician side. How? Because if we are not going to use the appropriate dose, right? Appropriate dose, right? So this is one of the important factor of not showing the response or showing the slow response. So this is very important duty of a physician to start the dose appropriately according to the status of that patient, right? This is important because if you are using the low dose, right, the concentration which is required for producing its activity, it will take time and it's not going to kill the bacteria properly or inhibit the growth of organism properly. Okay. Minimal inhibitory concentration, already we have discussed, is the lowest concentration of antibiotic that inhibits bacterial growth. So, to provide effective antimicrobial therapy, the clinically obtainable antibiotic concentration in body tissues and fluids should be greater than the minimal inhibitory concentration. And this already we have explained. Minimal bactericidal concentration, the minimum concentration of antibiotics that kills the bacteria. And MBC is the lowest concentration of antimicrobial agents that result in 99.9% decline in the colony count or the viral burden, right? Now, this is very important problem in our community, which is emerging rapidly, right? The resistance against the antibiotic. This is one of the major concern, especially in Pakistan, the emergence of resistance against different antibiotics. And before discussing the mechanism of antibiotic resistance, first I want to discuss how we are involved as a physician for developing antibiotic resistance, right? So one of the reason already I have discussed that as a physician, if I am not going to use number one the appropriate antibiotic, my selection of antibiotic is not according to the infection, right? Number two, I'm not using as a physician the appropriate dose. So, what can happen if we are not going to use the appropriate dose? Now we will give the opportunity to that microorganism to alter themselves, right? Because if we quickly kill the bacteria, if we quickly inhibit the growth, so we are not providing the time to give the chance to alter themselves, right? So this is one of the reason of the development of the resistance. Number two, that is from the patient side, and this point also we have discussed. We have recommended, okay, that you must take this antibiotic for at least 7 days, but when the viral burden decreases below the threshold value, the fever is subsided, now patient start thinking, why unnecessarily we take these antibiotic for further 3 days or 4 days, whatever, right? So, what is the problem? because already we have discussed fever is subsided when the burden decreases below the threshold value, but microorganism is still present in the body. So to decrease the emergence of resistance, if we completely remove or kill that organism, there is least chances for the alteration process, right? Alteration process, right? There is least chances, we are not giving the time so they can modify themselves, right? Because this is one of the important ability even in the microorganism, right? If we are giving the opportunity to them, they can modify themselves, they can alter themselves, and this is called the mechanism of resistance. So this is one of the reason from the patient side, they are not taking the antibiotic, right, for the complete according to the course that is recommended from his or her physician, right? So a variety of alteration or mutations can lead to antibiotic resistance. So mechanism of antibiotic resistance, one of the mechanism is the enzymatic destruction of drug. Now, this is one of the important ability, right? So if we think just like human beings, right, if we have a problem, so what we think, we think, okay, how we can overcome this problem, how I'm going to show some response, some activity, how I'm going to modify myself, just like that. This is another world of microorganism. They can also think. So one of the mechanism is they are start producing some enzymes which are responsible to destroy the structure of antibiotic. So this is called enzymatic destruction of drug, right? So number two mechanism, prevention of penetration of drug. They modify themselves, they modify the structure of cellular structure of cell wall or cell membrane. If any antibiotic that has to penetrate this structure and reaches inside the cytoplasm, suppose antibiotic which has to inhibit the protein synthesis, so for inhibition of protein synthesis it must reaches inside the cell. After crossing cell wall and cell membrane, then it can act on ribosomes and inhibit the protein synthesis. Clear? So if that microorganism, they are going to modify themselves and alter their structure, cellular structure, cell wall structure, cell membrane structure. Now that drug would be unable to penetrate this structure, alter this structure. So how this drug is going to reach is the site of action. Number third, alteration of drugs target site. This is another mechanism. Rapid rejection of the drug. You know, there is a term that we use, the efflux pump. Efflux pump. So normally, what is the compensatory mechanism? Suppose, because you know why we are using antibiotics, either to kill the organism or to inhibit its growth, right? So again, there is a just like you must think just like human beings, they microorganism also start thinking how we can get rid of this structure or these compound which are coming inside the cell and they are going to destroy us. So one of the mechanism is the efflux pump. So there is generation of the pump that what they are going to do, the incoming drug which is coming rapidly, these efflux pump uh, reverse back and reversing the entry of drug from inside to outside, right? So what will happen when drug is reversing from outside to inside rather than they are start reversing from inside to outside, so there will be no accumulation of drug inside the bacterial cell, right? So this is how uh, they can inhibit this process of destruction, right? So this is this rapid ejection of the drug from inside to outside with the use of efflux pumps, right? So resistance genes are often on plasmids or transposons that can be transferred between bacteria, right? So These are the different mechanism, and this is very important different mechanism, right? Effects of combination of drug might be you would hear that sometimes in severe infection we use the combination therapy, right? Okay, the single antibiotic would be insufficient to produce the desirable effect. So in that situation, we use the combination of two different groups. For example, and this example you must memorize, right? Because the ideal combination that we use in severe infection, one of the drug that belongs to cell wall synthesis inhibitor, and another drug that we choose or select belongs to protein synthesis inhibitor. So that will produce the synergistic activity, right? So that means synergistic activity occur when the effect of two drugs together is greater than the effect of either drug alone, right? So beta lactam antibiotic, that is the cell wall synthesis inhibitors, in which we have the different further group, penicillin group, cephalosporin group, carbapenems group, right? So these are the beta lactam antibiotic, because in this group, the antibacterial activity due to the presence of beta lactam ring. So that is why these antibiotics are labeled as beta lactam antibiotics. So basically, these antibiotics, they are going to inhibit the cell wall synthesis. So one of the antibiotic that is responsible to provide a space, like beta lactam antibiotics, they are going to inhibit the formation or synthesis of cell wall. Now there is no barrier for aminoglycosides. This is another group, and that belongs to protein synthesis inhibitors. And already we have discussed the protein synthesis inhibitors that will occur. This inhibition, protein synthesis inhibition, occur when the drug reaches inside the cell, in the cytoplasm, where it will bind with the ribosomes and inhibit the activity. Right. So beta lactam antibiotic, they inhibit the cell wall synthesis inhibitors. So they are going to provide a space, right, to remove the barrier of that cell wall. So this aminoglycoside will rapidly enter into the cytoplasm and inhibit the protein synthesis. So this is labeled as the synergistic activity. There is another term that is called the antagonism, that occurs when the effect of two drugs together is less than the effect of either alone. This is very interesting. So as a physician, we must, that is why we say that pharmacology is one of the important subject. The knowledge of pharmacology, why the knowledge of pharmacology is so important, because as a physician you must know the different drug interaction, different mechanism of action, different pharmacokinetics parameter of that drug, right? If you know this knowledge, so you are not going to prescribe antibiotic that is going to produce the antagonistic activity, right? So this antagonistic activity occurs when the effect of two drugs together is less than the effect of either alone. For example, bacteriostatic tetracycline. This is one of the important group of protein synthesis inhibitor, interfere the effect of bactericidal penicillins and cephalosporins. So that will that is the example of antagonism. This is another very important term that we use, and as a student, you must know this term, right? Chemoprophylaxis, right? Chemoprophylaxis. So first, we must know this chemoprophylaxis concept. You know, generally, when we use antibiotics, generally we use antibiotics when there is suspecting infection, right? That means after the occurrence of infection, we start antibiotic to overcome that infection, right? But Chemoprophylaxis means the drug that we are using, and at that time, that patient is not suffering from that infection, right? Or any disease. This is the broad term. Suppose we want to, and the best example, the best example is the uh, vaccination program, right? Vaccination program, where we use the expanded program of immunization, right? In children, we recommend that BCG and different vaccine. There is a program, so we'll have to give those vaccines to our newborn or our babies, right? Why? To avoid the future infection that can occur in that patient. So, to avoid the future disease or future infection, when we give antibiotic, though at that time that patient is not having that problem, but why we are using, to avoid the future infection, right? So in normal person exposed to pathogens, right, rifampicin 600 milligram twice daily during outbreaks of meningitis, right? In Urdu we say gardan tor bukhar, meningitis, right? The inflammation of the leptomeninges of the brain. So if these outbreaks occur in any community, suppose a patient that doesn't have that meningitis, but start taking rifampicin as a precaution to avoid the development of that meningitis. As soon as it to prevent TB in those recently infected, or even the patient, suppose in my family, one of my family member having TB, right? And I don't have at that time, right? To avoid the uh, future infection that can occur, right? So we can start the therapy with isoniazid. Otherwise, in a full-fledged diagnosed case of TB, generally we use the combination of four drugs. But a person doesn't have infection, but the persons in close contact diagnosed case of TB, then we should start the prophylaxis of isoniazid to avoid the infection. Tetracycline to prevent the plaque. So these are the important examples. And the key example already we have discussed the vaccination program. So this is one of the major example why we give the vaccine, though we don't have infection at that time. So why we are giving vaccine to those person who doesn't have infection? Why we are recommending? Because to avoid the future infection that can occur. So in person with high susceptibility to infection, opportunistic infection in immunosuppressed person like AIDS, you know most of the AIDS patient, that is also called HIV, human immunodeficiency virus, is responsible for this AIDS. So that occurred due to opportunistic infection. So this is very interesting concept. What do you mean by opportunistic infection? Okay, normally, you know, in a normal person, when there is invasion of any organism that can cause the infection, but normally the nature has developed a system in the form of normal flora, right? Normal flora in our body, normal flora present all over our body, on the skin, in the nostril, in the GIT, in the oral cavity, everywhere, right? So these normal flora initially fight against that invading organism, so they don't have any opportunity to multiply themselves. But when our normal flora activity is suppressed due to immunosuppression, due to low defense mechanism, right? So what will happen now? These invading organism have the opportunity to invade and multiply themselves. So there is no opposing activity that normally occur due to normal flora activity. So now they have the opportunity. So especially this opportunistic infection occurs in immunocompromised patient. So most of the AIDS patient, because they have low CD4 cell count, right? Immunity is very much low. So if they have opportunistic infection, especially lung infection, so death can occur due to that opportunistic infection. So in that patient, we will have to monitor closely and will have to avoid the opportunistic infection by prescribing appropriate antibiotic. Recurrent urinary tract infection, congenital and rheumatic heart disease, right? And prior to surgery, right? One of the example is the tooth extraction to prevent endocarditis. And this is the normal routine protocol in a dental office. If there is a need to produce any invasive procedure, the dentist initially recommend, okay, you will have to take the course of this antibiotic, then you will come on that date, so I will do the procedure, right? So why? Because the increased chances of endocarditis, if we are not going to give the coverage of antibiotic, and when we, because from that side, any organism can spread and can enter into the heart commonly. So that is why this is one of the top reason of giving antibiotic prophylaxis before the tooth extraction or any invasive procedure in the oral cavity. Before the colorectal surgery to prevent peritonitis and wound infection, right? This is the again a normal protocol. There is another term that we use, that is the post antibiotic effects. Post antibiotic effects, especially for staphylococci and gram negative bacilli, suppression of bacterial growth persist despite concentration of antibiotics below minimal inhibitory concentration, right? So this is called, even already we have said, generally the killing or inhibition of growth start when the concentration above the minimal inhibitory concentration. But there are some examples that in which the the antibacterial activity persists even if the drug concentration below the mid. That means if the concentration is present, even that concentration is below the minimal inhibitory concentration, but still that concentration is able to produce its activity, so it would be labeled as the post antibiotic effects. Now there is another term that we use related to antibiotics: concentration dependent killing versus time dependent killing. Concentration dependent killing, as the name indicate, higher peak concentration, higher killing action. And the key example, aminoglycosides and quinolones. So these are the two important group, right? And these example you must remember. You know, aminoglycoside group is one of the group under the heading of protein synthesis inhibitor. And we have very important examples of antibiotic under this aminoglycoside, like amikacin, gentamicin, tobramycin, right? Streptomycin. All these antibiotics are related to this aminoglycoside group. And in quinolone, we have different, there's a long list of antibiotic like ciprofloxacin, norfloxacin, moxifloxacin, levofloxacin. So these are the examples of quinolone. And quinolone, responsible to inhibit DNA synthesis. And time dependent killing depends on time above minimal inhibitory concentration, saturation of action on target, Beta-lactam antibiotic, vancomycin, these are the key examples that follow the time-dependent killing, right? So how much time is required to reach the minimal inhibitory concentration at which it's going to start its activity. Adverse effects of antibiotics can be considered as those occurring with all antibiotics, right? That we can say the general side effects and those restricted to specific agents. From the exam point of view, what we must remember, right? The specific uh, side effects. There are some specific side effects related to specific antibiotic group. Now, this is the conclusion. One of the major concern is the emergence of resistance. So, how we can avoid this problem, right? What are the precautions? So, minimize antibiotics unless bacterial sensitivity is known. There is a common practice in our community. We are very eager to start antibiotics, right? And both are involved, physician as well as patient, because sometimes if physician is reluctant to start the antibiotic, the patient, they are going to force that, no doctor, please start antibiotic, right? So if we are using uh, continuously, so increased chances of the modification in the structure of that organism. Ensure adequate dose, right? This already we have discussed. Are we using the appropriate dose, right? So this is one of the important mechanism, and this is one of the important mistake. And if we say okay, what is the important point from the physician side that is responsible for causing emergence of resistance, that is the inappropriate dose, right? Ensure adequate doses, making allowances for drug food interactions and complete course. This point also we have discussed. Avoid spreading infection by observing hospital policies for hand washing, asepsis, and single use equipment, right? Try to prevent contact between methicillin resistant staph aureus, right? This is one of the major concern, right? Especially in hospital setup. And vancomycin resistant enterococci by separating patients harboring these bacteria. Such contact could allow development of even vancomycin resistant, methicillin resistant staph aureus. Because when if a patient is showing methicillin resistance, uh, we can use vancomycin against that problem. But if vancomycin resistance develop, so it will create a problem, right? Hypersensitivity, 1 to 10% of patients are hypersensitive to penicillins. So through proper patient history, we can minimize this problem. Pre-therapy assessment of breathing pattern and scan to facilitate detection of any changes. So we can give the test dose before starting the infusion, right? And administer intravenous therapy. If there is a need to give the intravenous therapy, we should infuse slowly. Superinfection, and that is the similar mechanism that already we have discussed, the opportunistic infection, right? But there is a slight difference, right? In opportunistic infection, if a patient immune system is compromised, then invading organism has the opportunity to invade and produces its activity. Superinfection, if the normal flora activity is suppressed due to the use of antibiotic. Now this is the big difference, right? So in opportunistic infection, okay, in that situation, due to low immune activity, low host defense, low normal flora activity, invading organism has the opportunity. But in superinfection, the normal flora activity is suppressed not due to uh, immunocompromised activity, but that is due to the use of other antibiotic, right? So this is one of the important difference. So because when we suppose we are using antibiotic, okay, that antibiotic is very effective against the organism for which we are using that antibiotic, but that antibiotic not only kill the susceptible organism for which we are taking that antibiotic, but also suppresses the normal flora activity. So now the normal flora activity, when it is suppressed due to the use of antibiotic, the other microorganism, invading organism, they have the opportunity to multiply themselves. So that would be labeled as the superinfection. So how we can avoid this? Minimal use of broad spectrum antibiotic, right? Because broad spectrum antibiotic has increased chances of not only inhibit or kill the culprit organism, but also suppresses the activity of normal flora. Monitor fluid and electrolyte balance if diarrhea and vomiting occur, and be alert for Clostridium difficile infection, right? So this is one of the infection that is labeled as the superinfection, right? Normally, Clostridium difficile has no opportunity to multiply themselves, but if normal flora activity is suppressed, now this Clostridium difficile has the chance to multiply themselves and can cause the severe diarrhea. Small frequent meals may alleviate gastrointestinal disturbance. Stomatitis may be alleviated by ice cubes and mouth care. That is the mouth ulcer. Monitor for infection due to fungi. That is the one of the important Candida albicans. This is one of the example of superinfection. Sometimes if a patient is taking antibiotic for a prolonged period of time, increased chances for the development of fungal infection. Pseudomonas aeruginosa and enterobacteria. So these are the other examples that normally they are not going to produce infection, but if they have the chance, right, due to the suppression of the normal flora activity, so they can produce infection. If aminoglycosides are administered, monitor for worsening of TB and herpes infection. Therapeutic failure, so this is one of the problem. Okay, we are giving antibiotic, but that patient is not responding. So we must ensure that are we using appropriate dose or not, right? So ensure adequate doses and prompt administration, right? Certain antibiotics, particularly aminoglycosides, have a narrow margin between therapeutic dose and toxicity, right? So because the therapeutic index is the ratio between the effective dose and the lethal dose. This is important. So the margin is narrow. Suppose accidentally if we have double the dose, so it will produce toxicity,
एक्सक्यूज
right?
मी सर.
जी
एक्सक्यूज मी सर. जी सर,
हाँ
आपकी क्लास का टाइम एंड हो गया.
हाँ, बस हमारा भी लेक्चर भी एंड हो गया.
ओके सर.
बस एक एक मिनट दे दें, ठीक है?
ओके सर. ओके सर.
Okay, so this is all about the overview of antimicrobial. So these are the important points that we have discussed, and it would be very, very helpful for you, right? So thank you so much. ठीक है जी.
जी सर, मैंने चैट मैंने ऑन रखी हुई. कुछ अगर क्वेश्चन करने हैं स्टूडेंट को तो सर आप जवाब दे सकते हैं.
Okay, there is one question: is MIC and MBC checked in case of emergency? No, no, no. In emergency, already we have discussed. This is checked with the help of labs, right? So already we have studied, because when any antibiotic is introduced, right? That means we can use clinically is well studied antibiotic. All the studies has been done, right? So that is why anything which is introduced clinically or practically we can use, right? So, and the important point is in emergency, if there is severe infection, so we must know, okay, this is the antibiotic supposed to the broad spectrum antibiotic and cover more than one group, right? But before starting that antibiotic, right, because we are required the rapid effect, so the selection of antibiotic, then the selection of route of administration. In emergency we administer the drug intravenously, right? But before starting antibiotic, we must send the blood culture for blood of the patient for culture and sensitivity, so we can recheck its sensitivity. Maybe if we haven't sent the blood for the culture and sensitivity and we have started the therapy, so maybe that drug is showing the resistance if we get the report, right? So it will be confirmed that after sending the blood and you have started the antibiotic, when you are going to get the report and the antibiotic that you have started showing the sensitivity against that antibiotic, you will continue. If that antibiotic showing the resistance, so you can change the antibiotic, right? Okay, sir, what is the drug of choice, viral or static, if both are appropriate for a certain microorganism, right? So it depends. Now, this is the uh, clinical experience, right? What we must know at this level, okay, the concept, okay, these are the bactericidal drug, these are the bacteriostatic drug, uh, most commonly in our setup we are using in emergency situation third generation cephalosporin is one of the drug that we are using in emergency situation. And another cell wall synthesis inhibitor, because already I have told you cell wall synthesis inhibitor drug labeled as the bactericidal drug, right? So in emergency situation, we usually prefer to use the cell wall synthesis inhibitor. But if that drug is showing the resistance, then we can try the one of the aminoglycoside group. And this is another group, though it's protein synthesis inhibitor, but if we use the high doses, it can act as bactericidal, right? One of the key example nowadays in our hospital setup or in emergency situation, amikacin. Amikacin is the drug and one of the drug that is labeled as the life-saving drug. So that belongs to aminoglycoside, and in severe infection, we are using amikacin, and this amikacin belongs to aminoglycoside group, right? Okay, you mentioned the medicine flagell that has uncertain side of action. Can this medicine be in some way having adverse effect, as we don't know where exactly it acts? Okay, nowadays, uh, like the one of the important problem is the emerging of matronidal side effect related to liver injury. So nowadays, most of the physicians, they are not recommending metronidazole, rather they are using better form is the tinidazole, right? But at low doses still in the dentistry, because it can cover the uh, mm, anaerobic organism, right? Because we have a low number of antibiotics that cover the anaerobic organism, so it is very much effective. But now in the modern in nowadays, now we have antibiotics available that can cover both aerobic as well as anaerobic organism. Okay, so this is all about for today. Thank you.